Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. We're broadcasting live from the Dolph Simons Family Studio with our morning media update. Thanks for being with us this morning. We have some special guests with us today. We have special guests all the time, but today's guests are pretty darn special. I've known both of them for a long time, especially this older guy here over here to my left, Roy Jensen. He and I go back a long, long way.
Who still has his hair, by the way.
Oh, he starts early and often and goes low on the very first
Shots
shot.
fired.
Man, Jensen. I was about to say we've been through a lot of battles together. We have similar scars, and he goes for my hair length. Thanks, RJ. We'll get back to that. Which one of us is older, I wonder? Doc Hawk is here with us again this morning, Hawk Guy, and he'll give us our morning update around how things are going here at KU. And Jamie Wagner, one of our outstanding breast cancer surgery physicians and the leader of our breast cancer surgery program. So first, welcome to you all. And I should say Roy is the director of the NCI Designated Cancer Program here at KU. Trying to achieve comprehensive status next time. How many days and how many hours?
492 days.
And how many hours? Come on, you're usually sharper than that, brother.
Well, the hours aren't as important anymore because the we don't mail those applications in.
Okay.
They're
electronically submitted.
So, yeah.
All right.
So we don't have to know when the FedEx box is
closing.
Those
All
days
right.
are long gone.
Dana Hawkinson, how are you doing this morning?
Hi, we're good. Here at the health system, we have continued to have good numbers. We have 15 today. 7 of those patients are in the ICU. We've had some discharges as well, so which is good. And yesterday we were talking about modeling and what's going to happen in the city and in the community once people start opening up and getting back. And we have some numbers and some projections. I think we'll keep those blinded and see what happens over the next 4 weeks and see who comes out with the right projections. Hopefully it will be on the lower side of the projections, though, than what some of our other docs were predicting that will happen in, say, the next 4 to 6 weeks.
Yeah, we had a meeting last evening, and we were working on the modeling, and each of us came up with our number, what we think. We used our inpatient census we all, I think, anticipated some growth in the numbers, except one person said he thinks it's going to stay flat.
Yeah.
And I hope that he's right and we're wrong. That would be the best. So, Roy, this is a difficult time for cancer patients. Talk to us a little bit about some of the impacts to cancer programs around the country from COVID-19 and to cancer patients in general.
Sure. Thanks, Steve. Appreciate you having me on. So the cancer programs have been pretty dramatically impacted across the nation. And obviously that impact has varied somewhat depending upon the local severity of the COVID crisis. And but one thing's for certain is that many of the screening activities and a lot of the prevention activities that normally take place have been suspended. And we're very concerned that that could have a significant impact in terms of our cancer mortality figures, which have been dropping steadily for almost 2 decades now. And whether or not this crisis will precipitate an abrupt halt to that progress, well, we really don't know. But that's one of the things we're worried about.
We are concerned. And Dr. Wagner, out there in your area, especially with breast cancer surgery, that screening and preventive, that's just incredibly important. Talk to us a little bit about, has that slowed down from COVID-19?
It has slowed down, and that's actually something that, as Dr. Jensen was just mentioning, we've had a lot of concerns because we know that once screening mammography was implemented, we have seen a decrease in the death rate for breast cancer by 40%. So a lot of the concerns with the halting of screening in the recent weeks has been that we will start to see more locally advanced cancers, which require far more extensive treatments with unfortunate correlating low survival rates and higher risk of recurrence. In the last couple of weeks, we have been fortunate to slowly start to increase our screening again, and we're back to almost 50% of screening. And in the next couple of weeks, we have the opportunity with some very thoughtful approaches on maintaining physical distancing to continue to expand that further, because it's going to be very important that women get back to screening.
So what are some of those things that you're doing in the cancer program to help keep people safe from the fear of COVID-19?
Well, from starting with screening, since we were just discussing that, is the way we have really rolled out expanding those time points again. Instead of, for example, every 15 minutes, we're expanding them to every 30-minute appointments. We have people that are actually stationed throughout all of breast imaging to assure that we are appropriately sanitizing rooms after patients have been screened, as well as making sure that we're adhering to the workflows that have been put in place so that we can maintain the necessary physical distancing. Honestly, it's actually giving us a great opportunity that we've seen to further educate patients on COVID as well as cancer and screening needs. When we then move to the treatment areas, we're adhering very strictly to policies that we have implemented to everybody that's coming into contact with patients to being wearing masks as well as eye protection. We are also doing this for our patients so that all patients that are coming into any of our cancer center locations are also wearing masks.
Yeah, it sounds like a lot of good measures. How long do you think before we can get back to, say, full capacity of doing mammograms and other forms of breast cancer screening?
Well, our hope right now is that sometime in June we will be getting back to those almost pre-COVID levels. So really we're taking it 1 week at a time. If all the measures that we have currently put in place that we'll be rolling out over the next 2 weeks are successful, I think that we will be able to achieve it by sometime in June.
I think one of the things patients are afraid of is that somehow they're going to come into a healthcare setting, and because they're going to either run into a patient or a person or something like that, they'll get SARS-CoV-2 and it'll lead to COVID-19. Dana, have we seen that transmission occur in the outpatient setting or in the inpatient setting? Have we seen anything where a place where we think we've infected a patient?
No, actually, we've had very good experience with patients and healthcare workers here in the health system with COVID-19 and transmission of SARS-CoV-2. And actually, we haven't had any employee-to-patient transmission. In addition, our healthcare workers, it seems that our healthcare worker positivity rate is certainly the same or even less than it is in the community.
Yeah, I think it's actually been a little, I don't want to say significantly less, but about half of what we think it may be in the community. Yeah. Jamie, what kind of questions are you getting from patients about safety and what they need to do?
A lot of it is what we're doing within the clinic areas to be able to maintain that physical distancing, which fortunately we are able to assure them that we have many strategic plans in place. I think a lot of it is actually coordinating of visits, which we very much understand because we want them to come out of their homes as few times as they really need to. So we have been very thoughtful, again, on how we are putting together those appointments so that they're not coming in one time maybe to get an image and then also to see a provider, because physical exams sometimes are still very, very important. We've been able to launch telehealth to do that initial visit so that we can approach their in-person visit much more strategically and maximize that time. So bringing them in one time to get all the imaging that they may need, as well as all the provider visits, even coupling physicians like surgeons and medical oncologists. Honestly, it's really helping patients get that full picture of their diagnosis and treatment in a more efficient manner as well.
Yeah. Dr. Jensen, as you look around, I'm sure you've been in contact with programs around the country. Anything that cancer centers around the country are saying that patients should do, or special precautions being taken?
You know, I think that just following up on the discussion around safety, there's no entity, certainly in this area, that is more focused on the safety of the patients coming in than this place. And you know, came in this morning, every single person I saw in the halls wearing a mask. We've instituted a whole series of protocols and procedures to make sure that we minimize exposures as much as possible. And I'm really glad to hear that we continue with the fact that we have not seen a transmission of this disease from one of our personnel to.
And we work hard to look at that too, just to say we do contact tracing, do a lot of things to be sure. And also, we always say every morning now, we're saying we don't have a mask on because our distance is 7 feet, and it's hard to hear us with masks on through the microphone. So we do try and maintain our social distancing in the studio to make sure that we keep each other safe and therefore our families safe at home too. Well, let's see if our media have questions out there. We usually turn to the media first and see if there's any questions from reporters. Not hearing any. I do know that that there have been some questions about remdesivir, Dana, that have come in the last couple of days. Any thoughts about where we are with remdesivir? How many doses do we have? Have we given it? Any thoughts about the outcome related to it?
Yeah, we have given it to, I think, approximately 4 patients right now. We don't know the full outcomes of all those patients, just because we have so many different services and providers giving those to those patients. We do have the allocation from the federal government, which has come from the state to us, so we are working, and we just had a meeting right before this about really finalizing any criteria to really include the most amount of people that really need this drug so that we can give it to them. So we are working on that. We have given doses, and we continue to do that, and if we can certainly get more, we are always trying to get more here as well.
Are there any therapeutic advances that are on the horizon, perhaps?
You know, nothing else new that has a lot of promise. Certainly we are all looking at the anti-inflammatory drugs, the monoclonal antibodies. These are most of the time used in cancer patients or blood cancers, or autoimmune diseases as well. They help really just to decrease the immune system function. So those drugs and the remdesivir really are the main ones that we're using here and really have shown the most promise.
Yeah, we're pretty excited about some of those. And then the drug combinations. Can you address that for just a moment? Because we've seen some data out there about using different drugs in combination, A, and B. Would remdesivir be one of those drugs that can be used in combination?
Yeah. Certainly remdesivir hasn't been looked at in combination as some of these other drugs. There has been some other, the main one that came out a week or two ago was an interferon plus a ribavirin plus an HIV combination medicine. The data behind that is really not too good. We are continuing to look at that. That would be hard to give that combination as well, because even the interferons is hard on the body when you do give it. So we are continuing to look at that. Obviously, the hydroxychloroquine and the azithromycin has really been shown to not be effective in hospitalized patients and actually can have detrimental effects on a person's health. So we don't use that, and we're actually considering taking hydroxychloroquine off of our therapeutic regimen here. And this has been in consultation with experts, but also looking at the literature.
And really, so we're not recommending hydroxychloroquine prophylaxis yet. There are studies ongoing in which it has been, like the HERO study we talked about for healthcare workers.
Yeah, I think that's important to know.
But let's see those results before the public starts using them widespread, because A, they do have side effects, and B, they're actually meant for some patients with other diseases.
Yes.
And whether or not it's going to work in this one is, you can get the side effects, which can be significant, without the benefit.
Yep. So we need to make the distinction. We aren't using it for treatment because it's really been shown to be probably not favorable and, again, have detrimental effects. There are still ongoing studies about prophylaxis use.
Which means before you get the disease, it can help prevent you from getting the disease to high-risk folks like healthcare workers.
Correct.
Yep.
But if there's any, anecdotal information, or these published reports, but even patients who are on these drugs for regular indicated reasons, such as lupus or rheumatoid arthritis, they are still getting COVID-19. So we have to understand that even patients that are on these doses and these drugs on a regular basis are still getting it. So they don't seem to be really protected. But nonetheless, we still are waiting for the data to come out on the prophylaxis studies.
Yeah, all important stuff. All right, I'm going to pause for just a moment to see if there's any immediate questions from that. Not hearing, I'm going to turn to Roy Jensen. Roy, the cancer center designation comprehensive is 452 days, is that what you said? 492. I was just trying to see if you were paying attention or not. Does this COVID-19 crisis, is it going to impact how those things go about, or the deadline for that, do you think?
Well, all of NIH, including the NCI, have already moved their meetings to virtual. So all the grant reviews, all the site visits are now virtual, and so that will really impact how these things roll out. I've participated in a couple of those last week, actually, and it's a different experience than what it normally is. And I hope that eventually we'll be able to get back to in-person site visits. But the NCI has really had a pretty significant response to this, and one of the things they've taken on is trying to figure out all of the serologic tests and understanding what these antibody tests are really measuring and how good they are.
That has been a big deal. So, Jamie, trying to stay in touch with patients can be difficult at a time like this. Have you been using telemedicine to help do follow-up or to maybe screen patients? And how's that going?
We're using in both settings, and it's been going extraordinarily well. We are sometimes using it for patients that are calling in with a new complaint so that we can better understand what their new finding or concern is. Again, so when we bring them in, we're bringing them in for the right things. We're really utilizing it following surgery in our postoperative patients because it's amazing what actually you can do from a physical exam standpoint, just visually following patients after surgery. The medical oncology component is also using it because sometimes it's really just a discussion once we have that final surgical pathology and moving forward with the next steps of systemic therapy treatment, and that has been highly successful as well.
Good. So I understand we have some questions coming in from some of our listening audience.
We do. We have some cancer patients that are watching. One of the questions is, I am between radiation and surgery. Am I safe to do my own grocery shopping?
Dr. Wagner, what do you think?
I think as long as we are taking the appropriate precautions, as what we've even been describing here, we strongly encourage patients to wear their own mask when they're out, as well as being social distance as much as you can within a grocery store. Between surgery or between radiation and surgery, there is not a significant immunosuppression aspect of that treatment, so you should be very safe to move forward.
Of course, we always say, wash your hands, cough into your elbow, don't touch your face. I'm terribly guilty of that. My nose itches, I think, all the time, especially in the spring, which makes it a little bit difficult. But don't do your hair. Don't touch your hair like that. I just saw you do that, Jimmy Wagner.
I have another cancer patient, and this person is asking, is it safe for me to fly? The patient doesn't say where they are in their cancer journey.
Okay, is it safe to fly? I'm going to turn first to Dana. Dana, is it safe to fly at all right now?
I think, again, right now, depending on where you're at and what area you're at, you may be at the lowest amount of circulating virus in the community, so there's that to consider.
So if you're going to fly, this would be the time to fly, as opposed to waiting for another month after people have been out and possibly passing SARS-CoV-2 from one to another.
Because I think, the overall amount of flyers is probably lower now.
Yeah. Of course, the flights are low. They sort of canceled so many flights that some are starting to get crowded again.
But again, you are moving into an area where there is going to be much more foot traffic. The high-touch surfaces are going to be touched even more because of that. So, but if you can continue to do the same things, the simple things that you're going to be doing if you're going to the grocery store to get gas, wearing the mask, using proper hand hygiene, if you can bring alcohol sanitizer with you and get that on the plane, if it's in TSA regulations, using that frequently, not touching your face, those are going to be very important things to do.
Yeah. Jamie, what advice would you have for your patients before they fly right now?
Where they are in their cancer journey, I think, is a very important aspect to consider with any traveling, but in particular because of all the potential exposures that Dana was just speaking about. If you're immunosuppressed, you're in a much higher vulnerable population. Also, any of the contacts that you could potentially be exposed to could also inhibit you going on to the next stages. So, for example, maybe you finished your chemotherapy and you're not as immunosuppressed. Well, we are doing COVID testing on all patients going to surgery. So despite the fact that you may not have significant symptoms, if your test comes back positive, then that would push out your surgery and have a delay in cancer treatment, which unfortunately, of course, we would never want that.
Yeah, that makes sense.
What other procedures do you do COVID testing? This person wants to know about colonoscopy in particular.
Yeah, so I think, talk to us for a moment, Dana. we're screening almost everybody for procedures right now still. There's some debate about that because our positivity rate has been really low.
Right.
But we're continuing to do it for now.
Yeah, I think, again, you would probably get screened for that procedure. You're using some moderate sedation, some conscious sedation. You are going to be in an area, they're going to have to, usually with a colonoscopy, you're probably also getting an EGD as well, so that could be some aerosol generating. So likely for those procedures, you are probably going to be screened before, and that's for your protection because we know that in patients who undergo procedures, they have a higher risk of complications afterward. Now, certainly if you're undergoing a procedure in which you have to get intubated, an operation, that's a little bit more than a colonoscopy, but we are still screening people on the regular basis for inpatient admissions as well as for procedures, more for patient safety, so that we can make sure that post-operatively or post-procedure, you're going to have the best chance of recovery.
And actually, we kind of treat everybody the same as far as those procedures because we all take the same personal protective equipment steps that we would do as if we knew you had COVID-19. And that's really to protect each other from that.
A follow-up to that is, what is an EGD?
That's when they take a scope, they look down into your esophagus. Watch out for those big medical words, Hawk.
One goes below and one goes up. So
okay, you just said one goes below from when you're doing it from the top. One goes into your
one
mouth.
goes down and then one goes
comes in from
up.
your bottom, and the colonoscopy is the bottom.
You want to make sure that you have the EGD first before you have the colonoscopy.
Yeah, and the reason we do the EGD is to look for ulcers and things that are issues in your gut, so your upper gut.
Here's another one. This may require some defining too. What are some possible treatment ideas based on the multi-retroviral therapies?
Okay, antiretroviral therapy. That gets us into the whole AIDS world, and are there ideas that we can pull from there over to the COVID-19 world, Dana?
That has been a huge topic in the era of COVID, is repurposing drugs which have indications for other use, whether that's anti-inflammatory drugs, autoimmune drugs like hydroxychloroquine, or even other antiviral drugs such as the antiretroviral drugs for HIV. That is being done in different places. Most of this work is going to be just basic science, benchtop research looking at this. There also, now I saw another report of looking at antibacterial drugs that we use to even look to maybe see if that has any effect on COVID-19. So far, again, once the studies have taken place and the clinical studies in patients, because that is a lot different than just basic benchtop research. So you see an effect if you're just in the lab and it say, hey, I'm growing these cells in culture, I'm going to add this drug to it. Does it affect the viral growth? And it looks like it does. But then once you actually get to patients, that's the biggest step. And so far, we haven't found a lot of favorable evidence that these drugs that we're using for repurposing are really working to help improve patient outcomes.
Thinking about repurposing drugs, Roy, is something that the cancer program, and I know you've had a special interest for a long time here at KU, talk to us a little bit about how that process works, because people think, well, why would you take an old drug and use it for some new disease if that wasn't what it was intended for?
Sure. Well, that's a strategy that's really evolved over the last 15 to 20 years or so. And the beauty of that strategy is that we already know a lot about that drug in terms of how it's metabolized, the impact that it has, the side effects, and the dosage and safety. And so a lot of that work has already been done for us, so we can test directly whether or not that drug has some efficacy. And we come up with, which drugs to choose based on, basic science experiments where, say, we add it to cells in culture and it has an impact. And it's like, well, that maybe we could try this in a clinical setting. So Scott Weir and all of the folks in his operation have really become national leaders in this regard. And in fact, Scott won the Janet Rowley Award last year as a result of his efforts around repurposing.
And as I already called, that's a program that we kind of do together with Children's Mercy as well. There's some work there. Talk to us a little bit about that synergy.
Sure. Well, his program really extends across the entire cancer center, and so they have ongoing work not only with Children's Mercy, but the Stowers Institute, and of course, a lot of the infrastructure is out on the Lawrence campus associated with the School of Pharmacy. So it's a wide-ranging activity, and we've been able to actually move 5 KU drugs into the clinic in the last year and a half or so. So we're pretty.
That's a pretty big deal. Well, those are big home runs and great for patients too. Other questions out there today?
Yeah, this one might be also for Dr. Jensen. What is the HEROES research program I've heard about, and who is eligible?
I think the HERO study there's probably more for the hydroxychloroquine, Dana.
Yep. So the HEROES study it's for we're looking at prophylaxis using hydroxychloroquine against SARS-CoV-2. So again, prophylaxis means we're trying to protect you from getting the disease if you get infected with SARS-CoV-2. That is for healthcare workers because it seems like they are probably more exposed, or they know they have more exposure in treating COVID patients, and that is ongoing right now. And I believe it's heroesresearch.org. You can look it up, and you can apply if you're a healthcare worker, and they are still, I think, enrolling. So it's basically to say, if we give you hydroxychloroquine and we know that you're in contact with patients with COVID, or if you're a healthcare worker, will this protect you from getting the disease and protect you from all the other outcomes that come with the disease as well? And
there's like 15,000 people that needed to enroll in the study. Hopefully, our number of COVID-19 patients will continue to drop. As we reopen society, though, that's a risk, and we need to think about social behaviors and how well people are doing, and are they personally responsible once they get back out into society, because we're hopeful that will continue to keep the curve bent. You know, the Kansas City metropolitan region and western Missouri, Kansas deserve a lot of credit for having done some great work in bending that curve and making healthcare safer, because they did help us bend the curve. And now we just have to keep the curve bent and not let it come back because we want to go out and party too much. I think one day we even said, and I credited Travis Kelce, but I guess it goes to the Beastie Boys. I'm going to correct myself. You know, you've got to fight for your right to party. Now you have to fight for your right to party while wearing a mask, washing your hands, and not touching your face and coughing in your elbow, maintaining distance of at least 6 feet.
Right. And not gathering.
Don't too much. Yeah, gathering groups of smaller than 10. Just be safe. I got another story about that. I'll save it for a moment.
In our area, do we have data on cases by age and comorbidities? And again, the question is for us.
Yeah. Do we have data by questions of age and comorbidities? And we do, Dana. Do you want to talk a little bit about that?
We do. You know, I don't know all the exact numbers, but we do have data. We do collect that. We continue to collect it. We are also working with area hospitals as well to get all of that data. So, and that will go for various things. We're looking at all the patients that we've tried in these trials, such as the hydroxychloroquine trials, the remdesivir trials, the convalescent sera trials. We are collecting all that stuff so that eventually we will be able to really tease out those numbers and those trends.
You know, and what we can say is that Kansas and Wyandotte County and KU in particular, and really I think the Kansas City metropolitan area, is really not much different than what's been going on and what we've talked about nationally. I want to come back to that, but before I do, I want to ask Jamie a little bit. Jamie, are there specific populations of cancer patients who are at higher risk than others from difficult outcomes from COVID-19, and anything special that they should do?
Well, very much our immunosuppressed population. So anybody that is on chemotherapy agents, that's our highest risk population. Yes, we would like them to be taking significant extra precautions. You know, those are patients that, despite the phase 1 that we're in of getting back to, you know, small group gatherings, we would really prefer they, you know, self-shelter in place. limiting their exposure, if there's other members of the family that can help with shopping or still utilizing those home delivery services, those sorts of things. But that's a population we still have very strong concerns about. Also, for example, our transplant patients, our BMT patients that are trying to prepare for that transplant, we would definitely not want to see them at a higher risk activity and then miss that opportunity in that window for their transplant.
Okay, yeah, that totally makes sense. And Roy, nationally, any conversations around that you're aware of amongst cancer center directors?
No, I think that one of our biggest concerns does surround our bone marrow transplant patients, CAR T therapy patients. Yes. Any kind of significant manipulation of the immune system is that lowers its ability to fight the infection is obviously a concern.
Yeah, I think that clearly the other thing I would just point out when it comes to this question about what populations are most affected, we know that here that if you're over 70 and you have comorbid conditions, the chance of a not quite as good outcome is definitely higher than if you're 40 or 30. But we've had some deaths in patients who are younger as well, often linked to comorbidity. But occasionally we'll see what we have. We'll see what was called the cytokine storm patient, in which their body, for whatever reason, begins to turn on all of its autoimmune processes at once, and pretty soon the body begins to attack its own vital organs. When that happens, that's a rocky time, and so people like that can have some pretty difficult illness. So the point of saying all that is that our distribution of disease and the types of outcomes we're seeing here mimic what we've seen both nationally and internationally. COVID-19 is very real. And the outcomes can be very difficult if things don't get done early enough, and it will be a lot worse if people didn't take the healthcare advice of trying to shelter at home and maintain distancing, et cetera. Then we would see a lot bigger outbreak. But we bent the curve.
And even to that, we've been talking about drugs and therapeutics a lot during this show. Well, it's going to be important not only what drug or what therapeutic are we giving, but at what time during the course of the infection as well. And as we get further into this, we'll start to understand when is it best to give the antiviral. Does it have any effect late? Or when can we give some of the anti-inflammatory drugs like steroids, like tocilizumab? So we are learning those things on a daily basis as well.
It's another patient, multiple myeloma survivor, works in retail, and she wants to know if Dr. Jensen thinks it's safe for her to return to work.
Dr. Jensen, that's a hard one. You have multiple myeloma and a survivor. You're kind of long-term immunosuppressed no matter how you look at it. What do you think?
Yeah. I would hope that that you'd have an adequate supply of PPE if you return to work, and there's a number of other engineering solutions, putting up plexiglass barriers and things like that, hopefully you're at a place that has those available, but definitely you can wear PPE and make sure that you do that throughout the day.
And I'll just I'm going to pile onto this because I think it's important to say, whether you're multiple myeloma or I follow patients who've had lung transplants and have cystic fibrosis, the CF patients aren't necessarily immunosuppressed. Clearly, the lung transplant patients are. And I think you have to say, what is a safe environment? And the safe environment is what we've said. You should wear a mask, and the people you see should wear a mask. Ideally, you'd have a face shield on, or at least goggles over your eyes, because that can be a route of entry. You'd want to be able to maintain 6 feet of distance from folks, and you would want to be able to wash your hands or use alcohol sanitizer frequently, not touch your face, and put yourself really into that kind of a situation. If you can't be in that situation and you're immunosuppressed, I think you have to be really careful and thoughtful. That doesn't mean you can't go back to work, but I would talk directly with your physician and say, am I safe? Somebody who knows all of your circumstances and all the specifics of where you are with your disease, and say, here's what I can and can't do to protect myself at work. I need my job, but am I safe to go back to work? And I think you have to have that. We can give you these broad guidelines, but ultimately, talk to your physician who knows you best about those kind of things.
Yeah, your particular circumstances.
Yeah, there are different ones.
That's going to give the answer to that question.
Yeah, I think that's right.
And to that, if you're in retail, as this person was, and you're at a large store like Target or Hy-Vee or something with a lot of square footage, it's going to be easier to maintain that 6 foot of distance from customers and other people and not be in prolonged close contact with them. So I think it matters where you are working too. One of those big stores as compared to, say, a smaller boutique where it might be harder to maintain that distance.
We do have a couple of more questions. I don't know if Dr. Wagner.
Wagner, do you have one more minute? Dr. Wagner, Jamie, can we keep you for one more moment? A couple of questions headed your way, and then we'll wrap up.
And it has to do with age and cancer. Am I more at risk if I'm older? What do we know about COVID, my age, and cancer?
Yeah, the answer to this is going to be yes, Jamie, but talk to us a little bit about the effect of age in cancer.
Yes, because we know that with comorbidities before your cancer diagnosis, coupled with the treatment strategies that we need to implement, it will put you at a greater risk. That's honestly where the cancer community, in particular in breast, we've been taking these 6 to 8 weeks to really devise alternative approaches, things that we have previously seen in the literature, that we can maybe choose a different route. Instead of neoadjuvant chemotherapy, is neoadjuvant endocrine therapy more appropriate, which doesn't have that same level of immunosuppression. And there's actually been a lot of clinical trials that are currently in development to move forward with this. So we've actually learned a lot from this process. But yes, just like what Dr. Hawkinson and Dr. Jensen and Dr. Stites were just saying, looking at you as an entire person is important across the board, but absolutely with cancer treatment.
It really is. And we know as people get older that they are more at risk, which is why Dr. Jensen is more at risk than I am, because he's older than I am. The hair loss he referenced earlier in the program is largely his fault because of some of the things he's put me through. So, hey, the couple of things just to point out. We had some folks had a great photo from Rusty and Paula yesterday. Said it had a installation or a picture of he and his wife in a yard along Tomahawk that they wanted to show, and not a picture of he and his wife, but a picture that they saw of something about wearing masks. Your mask protects me, thank you. My mask protects you, you're welcome. And that's really part of the story as we talk around, as we talk about COVID-19. Yeah, we got the picture up on the thing. So, all right. Any other last questions that we have?
There is one about pregnancy and COVID. And what affects pregnancy? Are you seeing system-wide with COVID?
Okay, COVID and pregnancy, Dana. What are you thinking? We should go call Carrie Weinke back again and have her come back and talk more about it. But
for sure. I think we're lucky. We've always said that for the most part with this disease, we've been really thankful that for the most part children are spared from the disease. Obviously, we're seeing some effects post-infection, but for pregnancy, for mom and baby, I think we're thankful for the most part. We really don't see a lot of difference or changes or higher risks. Certainly, if you are a mother and you're pregnant, you are at more risk of having severe complications if you get influenza than if you get COVID-19. So I think on that front, we've been pretty lucky. And I think to date, they still haven't found any cases of mom giving it to baby or vertical transmission, as we would say. So
as we finish up today, Dr. Wagner, any final thoughts about COVID-19, cancer, breast surgery in particular?
As much as we've talked about the precautions, the one things that I would like to really encourage patients is we have found a very safe way to open up our cancer centers again. So to not delay any longer on some of those screenings that have been pushed out. But more importantly, you're your own advocate, and self-exams and just self-awareness of your body is important. So it is really important that if you are finding something abnormal, to please do not delay, because delaying this could really advance your cancer and have unfortunate outcomes on survival. So we'd like patients to I guess believe and trust in us that we are here for them and want to help them, and we are doing that in an incredibly safe manner during this pandemic.
Yeah, and thank you for all your great work around that. And to our folks out there, don't let fear hurt you, right? Yep. Don't let fear hurt you. Dr. Jensen, final thoughts.
One of the things that the Cancer Center's been doing in this crisis is to stand up a COVID disease working group that coordinates all of our clinical research activities around COVID, and it's modeled on the disease working groups that we have in the Cancer Center. And we've devoted a lot of resources to standing that group up, and I think we have 15 or 16 clinical trials up and going right now, just here at KU.
It is, and that's a remarkable story. And thank you both for all your great work in this field. You both are stars in this area, and we are so appreciative that you're here. And thanks for being on the program this morning. Dr. Hawkinson?
Yeah, the same thing. I'm just echoing what they were saying. Whether it's cancer or diabetes or heart disease or lung disease, please continue to stay in touch with your medical team. It's very important you continue to optimize your day-to-day health so that should you get COVID-19 or SARS-CoV-2, you will have the best chance at recovery because those other issues will not be as much of a problem. Continue to get your routine vaccinations and protect yourself against the diseases that we can protect you against.
Yeah, all those are really important. Hey, a note about tomorrow. Dr. Gary Gronzath and Dr. Colleen Lechtenberg are joining us with cautionary stories about stroke. One of the outcomes of COVID-19 is it can cause stroke, so we want to address that, but also making sure that you're safe from stroke at home, because we know people are having strokes at home and not getting the help they need. And like cancer, like heart disease, these are time-critical diagnoses. And don't lose your chance at a better life because of fear around COVID, because we know that we're a safe place and hospitals are safe places. When I was growing up and my kids were growing up, I tried to teach them the rules of defensive driving. I think they work for COVID-19. I know what caused me to think about this in the conversation this morning, but aim high in steering, keep your eyes moving, get the big picture, leave yourself an out. All of that is true about COVID as you go back into society. Keep looking around, make sure you keep in your distance, get the big picture of what's going on around you. Keep looking ahead. Don't get caught up with, I want to get out to a bar today, I want to get out to do that. Aim high in steering. Keep looking down the road and knowing that really what you're aiming for is to get past the next few months. We start getting vaccinations, we start getting effective therapy when it's really safe to go back out and enjoy the rest of your life and all that your life can give you. And don't shortchange yourself for decisions that you make today that could have big repercussions tomorrow. We're happier that thus far that we've been open kind of society for 9 days now, and we haven't had another surge yet, but it's still very early. And the bars and the salons and things like that, massage parlors, they just opened up. And we're going to have to see how that goes over the next 7 to 10 days. And by around June 1st, we'll be a lot smarter than we are today. Help us look really smart. Stay safe. And as long as you can, remember, there's still no place like home. We'll see you tomorrow.